Thank you, sir.
Thank you.
So, good evening, everybody. After this recap, I'm starting session with the ventilatory management during VA and VVA. So, my talk will be focusing on basically on physiology. We have already discussed it today, so briefly we'll touch benefits and harm related with the mechanical ventilation, especially during a VA, VVA, when we are more worried about ventilation, mechanical ventilator settings, so how it should be, touching about the evidences, and monitoring mechanical ventilation during ECMO and some future perspective. So if we talk about the pathophysiology of the lung injury, so it can be a direct and indirect lung injury. It can be because of the systemic illness, systemic inflammatory responses, which leads to a biotrauma, reduced lung compliance, and when patient try to breathe against this reduced lung compliance, there'll be self-inflicted lung injury, which all, including the ventilator-induced lung injury, all these contribute to the barotrauma, body trauma, atelectatic trauma, and ergotrauma. And this is what happens. I'm not going into detail, but focusing on VV ECMO. In spite of so much advancement in the ECMO, the mechanical ventilation strategies is still has not been studied much during various VV ECMOs and V ECMO. Most of the studies are related with the ARDS during a VV ECMO, but there were certain surveys which were performed and which clearly shows that they concluded that the patients, although ventilation practices in patients supported ECMO vary across the ELSO centers internationally, but the important thing that majority are centered on understanding that the targeted lung protective strategy should be followed. Even this is another survey on 2015. They also concluded that there is a variability in the ventilatory practices, but the lung protective strategies are again focused. This is another retrospective international multi-center study which concluded that the protective mechanical ventilation strategies are routinely used in the high volume extracorporeal membrane oxygenated centers. However, high PEEP levels during the first 3 days on ECMO supports were independently associated with the improved survival in the group where they had the high PEEP. So before proceeding, we should just recap the deleterious effect of the positive pressure ventilation. We all know that once the positive pressure ventilation is increased, our PEEP is high, and patient has a poor lung compliance. This all leads to a decreased venous return because of the right side of the heart is relatively thinner as compared to the left side of the heart ventricle, and which leads to a decreased cardiac output, and this increases the central venous pressure. There will be altered surfactant, which decreases the compliance. There will be inflammatory reaction, and the immune defense mechanism is disrupted. There's a decreased lymphatic flow, so the fluid will be accumulated, and this altered fluid flux ultimately leads to altered ventilation perfusion mismatch. And moreover, to maintain the oxygenation, we keep giving oxygen that leads to a tracheobronchitis, absorptive atelectasis, and definitely patient is not getting ventilated, there'll be hypercarbia, and ultimately diffuse alveolar hemorrhage. And we are well aware of the organ interaction or organ crosstalk, so it starts affecting your GI tract as well as the kidney. So you can understand where there's a decreased venous return, decreased RV inflow, decreased pulmonary venous return, and LV filling will be decreased. And ultimately, because of the positive pressure ventilation, LV compliance decreases. And this all leads to a ventilator-induced lung injury, um, as well as the hemodynamic variation. So ventilator-associated lung injury, if we see, it's a can be related with the barotrauma because there is increased transpulmonary pressure. Over-distension of the alveoli, especially those are the non-diseased alveoli, they are further injured because the lot of volume is pushed in those over-distension that leads to over-distension. So our target is always to reduce, keep the plateau pressure less than 30, and we are targeting a tidal volume less than 6 ml per kilogram of body weight. Once we reduce the tidal volume, there is a risk of atelectatic trauma, and that also when patient has a um, negative and expiratory transpulmonary pressure. So we have to keep the PEEP to prevent this atelectatic trauma. And biotrauma because of the mechanical activation of the lung, which creates a biological reaction. So what ventilatory parameters should guide for us to initiate an ECMO? So when the conventional ventilatory managements are not sufficient, and timing of ECMO usually is based on the degree of severity of the ARDS or lung injury. When there is severe hypoxemia in spite of high P, and when there is a pH is less than 7.2, basically there is a hypercapnia which is uncompensated, and the ventilatory settings are too high, like a high P and high pressures are being generated because of the poor lung compliance. But the duration of mechanical ventilation should be less than 7 days, preferably with a high ventilatory setting. So early initiation of ECMO with the severe ARDS improves the survival, even it has proven in the trauma patient as well. The purpose is to keep the transpulmonary pressure less than 25 centimeter of water, which is associated with a high lung injury. So the question comes, should we have the same ventilatory setting both for VA ECMO or VV ECMO? The answer is no, because we can understand well with the physiology that the VV ECMO, where the circulation is in the series with the native circulation, so it is only replacing the all or part of the lung function, because you can understand very well with this diagram that the oxygenated blood from the machine is coming, and the deoxygenated blood from the right atrium is being returned from SVC and IVC. It is mixed here in the right atrium. So the increased oxygenation, and now this the mixed blood is going to the lungs, and it is going to the left side of the heart. While on VV ECMO, where the circulation is in the parallel, so it is replacing the part of both heart and lung function, where it is in the parallel. So you are just putting this oxygenated blood in the artery itself rather than putting in the vein itself. So how this gas exchange takes place during the ECMO? The extent of non-pulmonary gas exchange required during ECMO is related to the limitation of pulmonary gas exchange. That how much the lungs are compromised, how much the lung contribution is there for a gas exchange, the extent of your support of ECMO will depends on that. But there is a limitation, because ECMO circuit does not has a this membrane oxygenator does not have the enormous surface as the lungs have. So there is always a restriction irrespective of the oxygenator you use. You cannot deliver oxygen more than 450 ml per minute. However, the lung capacity is much higher, because the lung surface area is very high. So when we talk about the actual oxygen delivery to the patient during the ECMO circuit, it is affected by so many factors like a circuit blood flow, how much is the blood flow, how much is the hemoglobin concentration, and what part of the this is getting oxygenated, is saturated in the venous blood. So VV ECMO, the circuit blood flow is related both to the inflow cannula and outflow cannula as well, along with the cardiac output. If you monitor the cardiac output, you can see when the cardiac output is 8 liters, your patient oxygen saturation is 94%. But suddenly, if you see that the patient's cardiac output, because of the inflammatory response or some stress, increases to 12, you'll suddenly see that their saturation has dropped to 80%. So this all depends on the cardiac output of the patient, and definitely inflow cannula diameter as well. And sweep gas flow, as yesterday Dr. Pradet has taught, that it will take care of the carbon dioxide level. So again, it depends upon how much the carbon dioxide patient is retaining, and you set your sweep gas flow accordingly. But in the beginning, you start with a lower sweep gas flow, and gradually you increase the sweep gas flow. You don't take out a carbon dioxide very rapidly. So we are well aware that when we are ventilatory making a ventilatory setting, we look for commonly for these parameters besides advanced ventilatory setting. So if we talk about the mode, there's a lot of controversy regarding the modes of the ventilation, because the AIDS net protocol says it does not make a difference. You use the assist control volume modes for ventilating these patients of the AIDS. But if you look at the common practices, most of the time it is the pressure modes which are preferred over the volume modes, so that we can restrict the pressure. Moreover, what is important that whatever your institutional protocol is, irrespective of the volume modes or pressure modes, whatever modes you are most comfortable, you should choose those modes for ventilating these patients. FiO2, we always begins with the higher FiO2, because these patients are on the 100% oxygen. But you keep going down the FiO2 and you come down even zero point 0.4 or less than zero point 0.4 up to zero point 0.3 if the patient is maintaining a saturation above 85%, so that you can reduce the trauma related with the oxygen toxicity. Then comes the tidal volume. We always look for a lung protective ventilation, and that has told us that we should decrease the tidal volume as low as less than 4 ml per kilogram of body weight. But the problem with this so much less tidal volume is that this will not going to remove your carbon dioxide. And this hypercapnia with this ultra-protective ventilation may lead to a complication, especially in a patient who have or having a head injury, increased intracranial pressure, or there is an increase in the pulmonary hypertension, or even it can affect the myocardial contractility and the decreasing in the renal blood flow. So one should be very careful while choosing a mechanical ventilation with the ultra protective ventilation. And here comes the role of the ECMO, where we can wash out the carbon dioxide and we can maintain our ultra protective ventilation. Then coming the rate, respiratory rate, more the mechanical lung stress. But the rate is important to maintain the pH and removing carbon dioxide. So what is suggested on ECMO that you keep the lower rate ranging from 4 to 10 so that you can reduce the mechanical lung stress. PEEP, again, whenever you are going for the lower tidal volume, it is going to cause atelectasis. So a higher PEEP is recommended, which maintains the alveoli in the open state even during expiration. Though we should remember that the higher PEEP are associated with the hemodynamic compromises by decreasing the venous return, and you need to have the frequent echo monitoring in these patients, especially when there is a right heart failure who are being treated with the VVM. So if you look at this, one of this study where they had the tidal volume of 6.2 ml per kg in the interventional group, and the control group, they had the tidal volume of in the range of 11.8 ml per kilogram of body weight, and their plateau pressure was, there's a difference 25 and above 25 around 32 to 34, and you can see that this high stretch is associated with the poor outcome in these patients. Similarly, keeping a lower tidal volume, and when you are using an extracorporeal carbon dioxide removal device, if you can see here, tidal volume is 6.3 versus 4.2 ml, and when extracorporeal carbon dioxide removal was done, we could maintain the pH of around 7.32, and after 72 hours of ventilation, there was significant improvement of the these pulmonary cytokines and marker of the lung protection, and there was no patient-related complications were observed. So, irrespective of modality, whether you are using a extracorporeal carbon dioxide removal when you are focusing only for carbon dioxide removal, you are using ECMO when you are maintaining both oxygenation and carbon dioxide removal, this is going to helpful you to maintain your ultra protective lung strategies. So what should be our strategy when we are ventilating our patient during an ECMO run? So we look for the different things what we want to achieve. We are trying to limit our alveolar strain by maintaining by we try to do ultraprotective ventilation. Second, we limit the atelectrotrauma. We limit the reabsorption atelectasis, and we try to avoid over distension. These are the four objectives we always look for ventilation when we are managing a patient on ARDS. So we avoid over distension. We keep monitoring the transpulmonary pressure, and we restrict our pressure less than 25. We limit the reabsorption atelectasis by decreasing the ventilatory FiO2 as less as possible. We increase the PEEP to maintain the oxygenation. We limit atelectatic trauma so by maintaining a high level of PEEP, and we limit alveolar strain by reducing our tidal volume. So this is the usual strategy when we are managing a patient with an ARDS. And this is what exactly happens. You can see a simple method. We follow a rule of 10, that inspiratory pressure 10, PEEP 10, and the rate of 10. And you can see here the tidal volume is hardly 20 ml is being generated. The patient is on ECMO, VV ECMO, and you can see the saturation is 85. So this is what happens in the beginning, and gradually once the lung starts improving, then you will see that the tidal volume started patient on the similar pressures starts generating the tidal volume. So the different guidelines, especially the ELSO guidelines, are the European network, CESAR trial, and the earlier trial, they have focused on all these parameters. And the ELSO says that the reasonable initial ventilatory setting where we have the modest PEEP with the deaccelerating flow, means using a pressure modes with a low inflation pressure with the respiratory rate of 4 to 5 breaths per minute can be useful and safe practice, but not the consensus recommendation. European networks again advocates the PEEP of 10 and restricting the tidal volume in a manner so that we have a plateau pressure of less than 25 with keeping a rate from 6 to 20 and decreasing FiO2 as low as 0.3. Similar observations were in the CISA's trial where they kept the PEEP between 10 to 15 and even in Aeolia trial they kept the PEEP more than 10 centimeter of water. So if we go for the strategy, initially we try all these patients are the respiratory failure or ARDS with the pressure control mode, keeping a peak inspiratory pressure less than 35 and plateau pressure less than 25. And we try to keep optimal PEEP around 10 to 18, targeting a saturation of above 85% at 90%. And if the patient is having a poor response and there is increase in the PaO2 FiO2 ratio decrease less than 70 and PaCO2 is rising, it means it's a time to add VV ECMO along with the mechanical ventilation. We start with the mechanical VV ECMO with the FiO2 of 1 and we optimize the gas and blood flow, restricting a peak inspiratory pressure less than 30 or to be precise less than 25, and we keep a PEEP of around 10 and decreasing the respiratory rate around 10 and targeting a saturation of around 90. So sometimes even with these maneuvers, the patient oxygenation is not maintained, so we need to prone these patients even during the ECMO run, which will help to reduce the collapse of the dorsal lung segments so that avoid this kind of subsequent over distension of alveoli can be avoided. But one has to be very careful because two cannulas along with the endotracheal tube, this can be challenging and risk during that move. But in the careful hand, it can be performed successfully. Recruitment maneuvers again, it is various approach or open lung approach or titration of PEEP. But during ECMO, so far there is no study for doing any benefit of the recruitment maneuver. Spontaneous breathing again in the beginning of the ECMO early phases it is not recommended because at that time patient volume of breathing is very high and it can further worsen the lung injury. So we keep sedated these patients and use in the early phases we use the muscle relaxant as well. But one should keep in mind that these relaxants are associated with the ICU acquired paresis, ventilator associated pneumonia. That our concerns are always there. So if the patient um, once the patient is stabilized, then definitely yes, we can use a ECMO in an awake patient who is spontaneously breathing. And sometime when patient lungs are improving, we might extubate these patients during an ECMO. But let's see the same objective, what we have looked for the VV ECMO, are they applicable on the VA ECMO? So truly speaking, not. Because in the VA ECMO, our goal is to have its own cardiac output. However, when we give the lung rest setting, what is going to happen? If the lung tidal volume is too less and we are reducing oxygen as well, it upper body hypoxemia, which is going to which may lead to myocardial ischemia and cerebral ischemia, that may happen. So that should always be kept in mind that keeping an ultra low protective ventilation may be harmful during VA. Let's talk about the epileptic trauma. So high PEEP, we try to give high PEEP to reduce the epileptic trauma. But what is going to happen in a patient who is having a severe myocardial dysfunction? Here, it is going to affect the venous return, which decreases the cardiac output, and we are going to increase the pulmonary vascular resistance as well as the right ventricular overload. So we are further reducing the left ventricular compliance. So a high PEEP usually is not recommended during a VA run. Let's talk about the reabsorption ectelectasis. Again, the high oxygenation, if we talk about the surgical patients, it is associated with a decreased risk of surgical site infection as well as the postoperative nausea if it is used for the short term. So VA usually is not for a very long time. So keeping even a high oxygen may not be as harmful as we think during the VV ECMO. So should we continue the normal ventilation during VA ECMO? Our target, not necessarily, but definitely not the ultra protective ventilation, but our target should be 6 to 8 ml per kilogram of predicted body weight. And we should adjust the PEEP, which depends upon the cardiac function. If the cardiac functions are bad, we should be lower on the PEEP so that we can avoid the deleterious effects of the PEEP. Um, and we should monitor the arterial blood gases, um, which can guide us. If we are taking from the right side, we can understand that how much oxygenation to the upper body is taking place. So adequate ventilation. What will be the adequate ventilation during an VA ECMO run? There should be sufficient myocardial and cerebral oxygenation. There should be less risk of atelectasis, and the possibility there we should always assess the possibility of winning on VA ECMO, because we can extubate our patient on VA ECMO. There's no problem because lungs until the lungs are compromised. So FiO2 should be adequate to ensure that there is sufficient myocardial and cerebral oxygenation, and this decreases the pulmonary vascular resistance and decreases the RV afterload. Ideal mode not known. You choose your mode depending upon which mode you are most comfortable. Adjunctive therapy, like a prone ventilation, I have already talked. Inhaled nitric oxide not have much role except in the RV dysfunction. Steroid, again, they have its own complication and associated with the post-ECMO mortality. Neuromuscular blockade, in the early phases, we do use, but should be avoided because it may lead to a critical illness neuropathy. Surfactant, it has shown the survival benefit in the neonates, but in adults, it's still we don't know that what is the benefit of the surfactant. And airway clearance by using the bronchoscopy, it can be safely performed on ECMO, but not should not be performed routinely. When you feel that there is a debris secretions inside and that needs to be sucked out to improve the lung clearance of the airway, but routine use is not recommended. So to conclude, the primary goal of the mechanical ventilation in patients who are on ECMO should be optimization of the respiratory variables to permit healing from the pathological state. The hemodynamic effect of the mechanical ventilation should always be considered when a patient is on ECMO. We must remember that there is a physiological difference between the VA ECMO and VV ECMO when we are adjusting the mechanical ventilation. It is important to consider the possibility that the patient on ECMO may not require invasive ventilation. So always assess your patient. If the patient is fine, there is no harm in extubating these patients on ECMO, especially on VA ECMO. On VV ECMO, it might be challenging because there can be increased work of breathing or there can be issues with the clearing the secretions, which may be difficult. But for VA ECMO, it is quite possible, and it should be performed on case to case basis so that if your patient is ready for extubation, you can extubate these patients. And most of the data actually used for doing a guidelines, it is associated with the ECMO in used in patients with the ARDS. So most of the time we just keep thinking of the lung protection, but on VA ECMO, if the lungs are fine, you really don't need to go for the ultra-protective ventilation. 6 to 8 ml per kilogram of tidal volume is sufficient. And short-term ECMO, possibly you need not to worry for the higher oxygenation. But more important is to ensure that the upper body oxygenation is well taken care of. What is important to remember? The acceptable range, the inspiratory pressure, plateau pressure should be less than 25. It is recommended. However, even less than 30 is accepted as per the ELSO guidelines. The PEEP should be in the range of 10, and the FiO2 should be as low as possible. If possible, it can go up to 0.3. And the recommended respiratory rate should range from 4 to 10 breaths per minute. Thank you very much. I'll be happy to answer any